We know that there is an increasing number of targeted therapies becoming available for molecular alterations in lung cancer. I remember 10 years ago it was mainly EGFR, ALK, and ROS1, but now we have more and more oncogenic drivers for which we have a treatment for. And the thing is that lung is not an easy organ to biopsy, right? It's not like, I don't know, melanoma or even breast that we can just get a tissue biopsy quite easily. To get lung tissue, you have to do a CT-guided biopsy if it's peripheral, or even an EVAS bronchoscopy. And the amount of tissue that you can get sometimes is not large enough to run all the tests we need: immunohistochemistry, PD-L1 expression, and also the tissue-based molecular profiling panel. So I think that's a very relevant issue, because sometimes there is not enough tissue to run all the tests we need to make a decision about first-line therapy in the advanced disease. And also, when we do, sometimes it takes a lot of time. In our study, the turnaround time for the 160 gene panel was 26 days. But the turnaround times are usually about that. First of all, the tissue has to go to the pathology to identify the subtype, the histologic subtype, then the other type of immunohistochemistry assays to further determine the subtype, and then it goes for the molecular profiling. Of course, that's one of the caveats or the limitations of our study of the plasma-first approach, right? Plasma-based molecular profiling can give us information about the molecular alterations, but it does not give us any information about histology, right? So that's why in our study we still need the tissue, right? And I think that's not going to change in clinical practice. We still need the tissue to know the diagnosis, the histologic subtype, but I think plasma can also add a lot of value in terms of accelerating wait times and improve patient outcomes because of that.